All right. Hello, everybody. Thanks, everyone, for having me. And I know we're closing out a conference, so I'll try not to go on. And more to the point, though, I'd love to actually get time for a Q&A. Because the things we're going to be talking about perhaps will be a little different from the rest of the conference. You're not going to see much data. There's no technology or innovation per se. But hopefully the talk will prime some thoughts. And you'll see the slides I have are simply just that, just prompts to get us thinking, specifically trying to approach serious illness and end-of-life care, some very difficult juggernauts within healthcare, but trying to come at the subject from a slightly different angle. And I guess on that note, guys, I should say, as we get to Q&A, I'm obviously a patient, and I'm a physician, and blah, blah, blah. And I welcome questions on any of the above. I mean, when you do this kind of work, the personal and professional intertwine dramatically in some ways, and for me, certainly it's been the case. So any questions on the table, as far as I'm concerned, hopefully we'll get there soon enough. So, all right. So again, I warned you, it's gonna be slightly different from the rest of your talk. Hopefully that's a good thing. This guy, you guys might recognize the staff. So the rod, it's the rod of Asclepius, and that's the single serpent wrapped around the rod. That is the symbol for the American Medical Association. And this is the origin of it. So Asclepius was a god, half mortal, half god. And there were temples to Asclepius in ancient Greece. At the same time as Hippocrates. Okay, so this guy was sort of the god of the healing arts. And his story is very informative for us and helpful. So he's the son of Apollo, God, and a mortal woman, Coronis. And apparently Coronis was unfaithful or untrue to Apollo, not clear. I haven't read the documents, but apparently he was upset with her, and he did what gods do back then. He killed her, threw her on a big fire. But he realized that she was pregnant with his unborn son, Asclepius. And so he couldn't bear to kill his unborn son, so he plucks Asclepius from the womb, but is ashamed of him, and so throws Asclepius out into the woods to fend for himself. And you'll often see Asclepius depicted with a lame leg, a leg injury, and always the psychic wounds of abandonment. So the myth of Asclepius is really powerful for us in medicine. So he goes on to be the god of health and healthcare. God of healthcare, that's a funny phrase, but god of health. And how does he learn this art, this craft? He learns the craft by tending to his own wounds, physical, spiritual, psychic, etc. And he does this so well that he gets so good at his job that he either brings someone back from the dead or is about to bring someone back from the dead, and Zeus gets wind of this and says, oh, no, we will not have this, because the one divider between the gods and humans is mortality. So he throws a thunderbolt through Asclepius, and that's the end of that. So two takeaways from the myth of Asclepius. One is this idea, the archetype of a wounded healer, that a normal life entails wounds. And that these wounds are, among other things, incredible teachers. We learn from them. And it's particularly poignant when you are, as a clinician, as I am, when you're caring for yourself and caring for others and see overlap between the two. It's not a selfless or a selfish pursuit. It's all kind of one and the same. I suppose the second takeaway from Asclepius is that we just don't muck around with mortality and not expect some fallout. I suppose is the easiest way of saying that. All right. So again, I'm a palliative care clinician, guys, so this is the lens I see the world through professionally. But I think there's more, I think there's something for all of healthcare in it, and we'll get to that. Okay, so why? These three little letters, I think, are so undervalued in healthcare. Clinically, on the floor, these moments of, stopping and asking ourselves, why are we doing this? Are we pursuing this intervention because we want to test it out? Is it a research paradigm or initiative here? Are we doing it just because we can? And that often happens in medicine. Well, there's a new thing to try, I might as well try it. We rarely stop and say, well, why are we doing this? And this is a big problem. This is where we run into trouble. And the other question, the sort of existential question of why, putting that in the air I think is very important for all of us. Why are we here? Why do we do this work that we do? But more tellingly around the sort of healthcare system, the big why for my money is, you guys know this, like there's so much devotion in healthcare. The amount of effort people go through for the privilege of working in healthcare, the training, the debt they take on. And I don't mean just clinicians, I mean all of us. This is a really difficult, complicated world. And we go through a fair amount of hell just for the honor of working within it. So how do we reconcile all this devotion on one hand that exists in healthcare? It almost makes me want to weep when I see some of my peers at work or when I think through the doctors and nurses and social workers that took care of me. It's amazing. And so we have that truth, and then we also have this truth that our healthcare system somehow fails us often enough. Whether it's through, did you guys see this data that the third leading cause of death in the US may be medical error? I can't quite believe that data, but even if it's in the top 10, that's pretty tricky. And we all know just the experience, for those of us who've been patients, the experience of even well-intended clinicians can be pretty miserable making. And at some point, healthcare can become the source of the suffering, which is for us in the clinical ranks, and perhaps everyone in this room, that's a horrible conclusion. And it doesn't jive with our intention. Okay, so how the heck do we get to this state? So, all right, well, let's go back in time again. This is 1846. This is the Aether moment. So at Massachusetts General Hospital, Aether is harnessed, a person is put to sleep, a tumor removed from their face, the person's woken up and lives happily ever after for a while. That's an amazing moment. Anyone who here's had surgery should be very thankful for this development. But what ends up happening here is it's sort of a start. This is mid-19th century. Technology revolution, industrial revolution in full swing. Medicine and science get in bed together. And that had not always been the case. You guys probably know that. But from here on out, for the next 170 years to now, it's the scientific method, it's objectification, specialization. And you put a place like my institution, UCSF, you've got ENT guys who specialize not just in the nose, but like in the left nostril. I mean, it's like super duper focus, which is amazing, right? I want to be really clear in my critique. I love healthcare, I love working in it. I am alive because of it, so I don't want to come off as ungrateful. But what I'm trying to get at is there's fallout for our approach to medicine in this last 170 years. This innovation will pull us through. Technology will pull us through. Work harder, get to that next gizmo. That's going to make everything better. We'll live happily ever after. The theory was that disease was a source of suffering. Root out disease and everyone's just great. What I think we hadn't reckoned with was the insistence of suffering, the insistence of death, that the utter normalcy of those. And no matter how much we push back on them, they keep finding a way around. So that's a reality I think that we're in the midst of coming to terms with. That's not a failure per se, that is human nature, that's life. So we are now in this sort of fallout of this objectification approach, right? And I'll come back to that in a second. Okay, so, and I'm trying to answer my own question of why do we have this mismatch between our outcomes and the intentions in healthcare. I think when you sort of think through all the devotion, I think it has something to do with the fact that the system isn't designed quite right. This does feel like a design issue. And I don't think it's too pat to simply say this, that for 170 years or so, we have focused on the disease, that the person with the disease was sort of incidental. They're sort of a vector for the disease. And those of us who have spent time in an acute hospital as patients, you get that feeling, right? You're processed. It's throughput. You're homogenized, you're put in a bland gown, given bland food, and you just march, you move along. And the best thing you can do as a patient is sort of numb out. Anesthesia, numbness, and just try to get through it. Now, the problem is that hurts the soul on some level. We'll talk more about this too, but maybe the problem is if we're focused on disease, then we're invested in the disease. We're not invested so much in the person. So maybe there's something to this idea that the system needs to be redesigned around the person who happens to have the disease. That little detail seems really, really important. And beyond that, you might even say, okay, so the patient-centered care makes sense, sounds good. But the truth is, none of us is autonomous, none of us is in a vacuum. Where so much of the healing happens really is in the relationship. The patient to the doctor, nurse, social work, family, etc. These are all relationships, and that's how these experiences play out. So maybe what we're missing, maybe the relationship has gone missing in medicine. The 15-minute encounter is insane. It is insane. And we keep asking more of our doctors, more of our clinicians, more of the healthcare system. I honestly feel it's unfair. I think we ask too much of the healthcare system. You know, it's become the ER has become the church, has become the family table. I mean, it is where things go to get worked out. It's the default place to end up. That's probably dramatically unfair to the healthcare system. Okay, so you guys probably, has anyone here not heard of palliative care? Right, I mean, yeah, those days are over, thankfully. But it's still a hard field to define. So let me just shut up for a second, guys, and let you, can you read that? Can you see? Yeah, I'm just gonna let everyone read it. This is from CMS. You know, these are not poets at CMS, but this is a pretty remarkable definition. Okay, so think about this. For one, suffering. Suffering is the fulcrum, not a disease, right? Suffering is not a disease. You can make this point very easily. Who here has not suffered? Right. It is normal. It's not only normal, if you think through how you learn and how you grow in life, suffering seems actually pretty important to that process. In some ways, I wouldn't wish a lack of suffering on my worst enemy. There's too much good that can come from it. In some way, right? So there's a sort of a natural, necessary suffering in life. The gap between the reality you would wish for and the world you have. That's how I understand suffering. And that's the wedge in me that opens up when I'm suffering. I wish for something I don't have. You know, and that gives us your two responses. You can quit wishing for a life you can't have, or you can go about changing the life you have. And I think most of us try to do both. But one way or another, my point here is that suffering is elemental. It's actually even instructive. But there's a huge distinction between sort of necessary, natural suffering in a life and the invented stuff. The unnecessary suffering, the way we actually feel ashamed to be sick. So not only am I depressed, I have to be embarrassed to be depressed. Our language, we beat each other or we pummel each other with our language. There's all sorts of ways we make life harder than it needs to be. It's plenty hard to begin with. So necessary suffering is a powerful force, and it's something to pay attention to and learn from. Unnecessary suffering is something for all of us to be very disciplined about rooting out, lest we be gratuitously causing harm. Okay, so suffering, huge deal. We all do it. That makes the framework for palliative care empathy. We all have access to our own experience around suffering. Contrast that with, like, say, oncology, named for a disease, or nephrology, named for a body part. This is something named for a subjective experience. I can't test you for suffering. I don't get to be the professional. I don't get to know more than you do. The other thing that's so beautiful about this work is this has a way of leveling us out. It's human to human. It's not doctor with special knowledge up here, lowly patient who just should sit still down here. This is side-by-side kind of work. And that's where work is so dang beautiful. So that's good news for clinicians, that's good news for patients. Okay, the other thing to say about this definition, excuse me, bless you, is couldn't you just cross out the phrase palliative care, the words palliative care there, and just put in health care? I mean, most of the people I know who go into clinical work to do this. Even if they're super focused on a disease or a surgical technique, those guys are focusing on those things on behalf of the human being, right? So I'm not saying us to turn down our vigilance or work less hard, but reminding ourselves why we do this work. It's on behalf of the human being. Most of us in clinical medicine are interested in helping people suffer less. That's the beautiful intention in this work. And that's sort of plainly laid out in palliative care. And I will say this about palliative care. It's a subspecialty since 2006. A goal for us in the field, by the way, would be for the field as a subspecialty to go away. Do we really need a subspecialist to tend to someone's suffering, to tend to the family's grief, to communicate well, to ask open-ended questions? This is the work, the sort of nuts and bolts of palliative care. That's really basic stuff. Do we need specialists? Well, right now we do, because I believe the healthcare system has gone a little bit astray in this disease-focused technology, sort of hyper-driven, innovate our way through versus learn to live with what we have, adapt, grow. So, all right, I'll get off that particular soapbox. But I just would leave you with this idea that someday, maybe if we have our way, if palliative care can help kind of realign care and remind us all why we're doing this, then maybe the subspecialty goes away, which I think is a beautiful idea, that this field would design its own obsolescence. We don't need to spend too much time on the wheel of suffering here, but I guess the other thing that's important about the subject is, no one's an expert on suffering. This work inherently demands interdisciplinary work. If that's the subject matter, no one discipline has a lock on it. So you have to have doctors, nurses, social workers, chaplains, at least, right? Music thanatologists, art therapists, administrators, everything that goes into the custodians at the door, every little piece that goes into the experience of being sick and trying to be healed is relevant. It's a huge invitation, in other words. Okay, now I'm gonna kind of just go through a bunch of prompts here with you guys. Again, take them or leave them, just sort of food for thought. But in medicine, so palliative care often feels like a consolation prize. Like you go into palliative care when you're giving up aggressive care. For one, you guys probably know this, but it's really important. You saw in the definition, there's no mention of death. Palliative care works best, upstream. Why do we wait to tend to people's suffering until they're dying? All of a sudden that becomes relevant in the final hours of life. Why is it not relevant upstream? But anyway, we talk about this idea of quality of life. But when we talk about it, when I hear the tone of our voice, we usually comes off like a consolation prize, like a second place. Like, I'm so sorry, Mr. Jones, we can't cure your cancer, but we can go for quality of life. It's like this sort of second place finish. And you say, well, A, why aren't we tending to quality of life earlier? But B, the bigger point I'm making here is, isn't quality of life the bigger prize, not the consolation prize? Put it this way, like, why are you interested in having your health? Why are we all interested in promoting health? If you have your health, you have everything. I'm not sure about that. First of all, health, well-being is not the absence of disease. Health is not the absence of disease. I know a lot of people with really great lipids and blood pressure, et cetera, who don't meet criteria for illness in any kind, but are walking zombies. There's something more. I'm interested in having my health on behalf of my quality of life. That's the bigger prize, is my point. So maybe we should be concerned with it right out of the chutes, not when our health is failing. Then we can go for the second easy thing. It's not an easy thing at all. I think one of the reasons we keep orphaning this subject is because it's subjective. And again, quality of life changes the power dynamic. My patients tell me what their quality of life is. I don't bestow that knowledge on them. They tell me. Okay, another sort of inversion that palliative care invites. Curing. Curing's amazing. I'm all for it. The problem is the healthcare system tends to fall down when someone's beyond cure. And that's the sin, is the abandonment. I have never met a patient who is mad at me or any of their clinicians for not somehow curing cancer, or railed that hearts fail. And speaking as a clinician, I don't burn out because cancer exists, et cetera. I burn out because the system that I'm working in pulls me away from people right when they're the most vulnerable. And I have to contend with either abandoning that patient or somehow trying to squeeze even more work in. We don't make space for this. Not in a curing mentality. But so isn't there something bigger than curing? At some point, we're all incurable. So if we're really trying to keep working with people all the way to the end, we have to have a bigger goal than curing. Healing, I'm suggesting, would be that goal. Now, healing is an internal process largely, right? It's something that we do ourselves in conjunction with others. It's not, it's not this me passive agent who just gets healed. It's usually an engagement between people. And healing, the root is being whole. I've learned in my own life, I can be dismembered and be whole. You can be deathly ill and be whole. You can be intact as a person. And I've met many people who are dying, whose bodies are literally falling apart, who are whole. They're dying healed. It's an amazing and beautiful, beautiful thing. Again, it's a bigger, vaguer goal. And part of what we in medicine have to do is let go of our control freak impulses. Part of this is an invitation to work with other disciplines, but also to really work with our patients in a different way. It may feel like we clinicians are losing control, but the truth is it's taking some of the onus off of us, some of the pressure off of us to work miracles. I did my internship in Milwaukee, the Medical College of Wisconsin. The Frederick Hospital was the main hospital we rotated through, and the tagline was, where miracles happen every day. I friggin' hated that. It was so hard to walk in that building every morning because I can't work miracles. Why do we market to people like this? We just blow up expectations and then make everyone feel like a failure, including the patient. I didn't get a miracle, I guess God doesn't love me. I didn't work a miracle, I guess I suck as a doctor. It's just it gets crazy. Anyway, I'm getting on more soapboxes. I'll move off this slide. Okay, here's another one. Again, learning from serious illness and end-of-life care. Acute care, we do that pretty well in America. We do it generally very well in a lot of ways. Where we get in trouble is when we have to care for people over time. Chronic care. Chronos. It's in the word, time. And one of the reasons why we in palliative care, and I particularly really want us to craft a worldview as an industry that includes suffering, that includes the normalcy of mortality and death, is because if death is in our worldview, then time is in our worldview. And we treat our time preciously. And then wasting our patients' and families' times then becomes a sort of a negligence. But you have to reconcile death before you get there. You have to understand that time is precious. And then you can work with it. If you don't let yourself acknowledge that death happens, then you will not acknowledge that time is precious. All right, so these are how these things kind of come together. And you can see in a lot of ways, and we as an industry, if we keep running away from mortality or deeming it a failure, we're not going to really reconcile the clock. And we're not going to get really good at chronic care. And we're not going to exercise the muscle of caring for each other over time. It's harder. Okay, this is a slide just to remind us, this is a pet peeve. I think we give words so much power, and I'm all for advanced directives, state your wishes, amen, we need to push these. But it's like, if you can state your wishes, then maybe we'll honor them. But if you can't say them, then all bets are off. There's so much power put into the word. The truth is, of course, in communication, it's all going on. The words are a bit player. There's the body language, there's posture, there's the eye contact. You name it, there's guts and vibes and all sorts of things happening. And I guess I'm just trying to say that in healthcare, we need to push back these walls too and create a sort of a mode of communication that includes intuition. So for example, patients who have advanced dementia, for example, and who may end up with a feeding tube, And if that person can't tell us they don't want that feeding tube, well, they're gonna get a feeding tube. But how often have you seen, perhaps, people with dementia pulling their feeding tube out every chance they get? Are they not communicating to us? Do we really need to hold them to this idea that they need to state a word for us to believe them? No. I think what drives that is mostly concerns for lawsuits. Okay, anyone know who this is? Florence Nightingale. Florence Nightingale, so she came around in the 19th century too. I think she wrote this book, Notes on Nursing. It's still in print. I think she's 1860 or so. So not far removed from the Aether moment we were talking about earlier. And so in other words, so she's at this time where medicine and science are all in love with each other and everything's going a certain way. But if you read this book, you will see that she spends a lot of time talking about fresh cut flowers or the power of a window in a room. And she even talks about the kind of floor wax she likes to use in her unit because it has a certain feel, a smell. Because she understood that living with illness and caring for people with illness is an experience. It's not a moment in time. It is an experience over time. And there's so many things that go into an experience, as we all know. And all those things are relevant if our goal is quality of life, if our goal is healing, etc. So also it's sort of good news for us. A lot of these fixes are not that complicated. Kindness, light, basics. I think we just got in trouble because we forgot the basics. But I push you guys to this book, and it's specifically because it points us here, this word, the antonym of anesthesia, aesthetics, aesthesia, feeling. This is a really powerful mode for us in healthcare that's gone sort of underdeveloped. It's one thing to talk, we've only recently gotten serious about treating pain, for God's sake. So we've helped people hurt less, but there's something really powerful about feeling anything. Depending on what your belief system is, we all die, but who knows what's coming next? But I think we could probably all agree that this body dies, this life goes, I'm going to lose this body. And why is that sad to me? Why is that hard? Well, because I love this body. And why do I love this body? Because it moves me around the planet. It allows me to feel things, hear things, sense things. That's its job. This amazing instrument that we're going to someday lose, an act of appreciation for this instrument is to let it feel things. And in healthcare, numbness is not a great goal. It beats pain as a goal, but I think we can do a lot more if we really tend to this sort of sensory experience of being sick, of working in a hospital, etc. It's a very huge domain. Aesthetic dentistry and other things has sort of taken a surface view. It sort of means like white teeth now, or an esthetician might help your skin look pretty. And pretty is cool, but the whole point is the word is much larger. It just means the senses. And the other thing to love about the senses, for a lot of us are going to find our way to dementia one day. Intellectual failure, in some way we're not going to be able to count on our frontal lobes to pull us through. So you might say, gosh, well, that's it for me. When I can't think anymore, I'm done with life. That may be your point of view, but we as a system, certainly as clinicians, that would be a projection. And ultimately, my goal is to help people live until they die. And in those periods where they can't count on their intellect to pull them through on everything, they can count on their sensory life. You don't have to have a thought to have a feeling. And really, when I stop and think about it, at least for myself, sure, I'm interested in being alive, but I'm really interested in feeling alive. That's kind of where the rubber meets the road. So this is a big, big area, and I think it's really ripe for exploration. What to say? There's a couple thoughts on this one. So meaning, there's a thing called existential suffering in palliative care. We talk about this. It's sort of, existential suffering is sort of the suffering that's left over when you've gone through sort of pain, depression, anxiety. So if a person's still struggling and you've ruled out all these diagnoses, then we might say there's existential suffering. It's sort of this catch-all. But really more specifically, existential suffering, I think really means is a crisis of meaning. We just can't, our patients, ourselves, just can't make meaning out of the facts that we're seeing in our life. And that's hard, right? Because as human beings, meaning is a hugely compelling force. Meaning, finding meaning or making meaning pulls us through the day. It's an incredible force, has so much momentum to it. And as human beings, we can inject meaning into just about anything. It's a powerful thing. And maybe we've all known people who seem to hang on a little bit longer because they have found meaning in their life. They have some purpose in their life. It can will us forward. I'm all for it. I talk to some of my colleagues who aren't in this work, and I talk about existential suffering. They kind of roll their eyes and say, oh, that's not my domain. I'm here to fix elbows or whatever else. My point to them is you can shirk that responsibility, but patients are going to be making meaning from every single thing that you say and do. Every moment in a hospital setting, everything is so charged, and you can ignore that, but at your own peril. Both your own peril as well as the patient's. Because making meaning together is a really joyful thing. So I'm all for it. But I also want to put a plug back to sort of the aesthetic thing for a second. There's something really powerful about meaninglessness. Sometimes I can't just find meaning. So what's on the far side of that when I can't find or make meaning? Well, you might put it here. This is a slide to remind me of this, is mystery. I don't know. 3 very hazardous words as a clinician, but really powerful as a clinician. I was taught to really never say those words, and if I heard myself thinking those words, I should just, it was a call to go back to the library and try harder, study more. I'm all for knowledge. What a weird time we live in, right? So we pretend to not know things that we know, and we pretend to know things we don't. It's a really strange time this way. So I'm not voting for willful ignorance. Let's know what's knowable, and let's make space for what we just can't know. The smartest person in this room, I guarantee you, would admit that they don't know everything. There's just too much mystery out there. And that's not ignorance. That's not bad. That's powerful. It keeps you curious. It keeps you humble. It keeps you looking. And even if you do none of those things, it's just amazing that we're these little bit players sharing a planet at the same time in the middle of this galaxy, in the middle of this universe. It's just wild. Life is weird. And we should have some sense of that, because our patients are really experiencing the weirdness of life. And it's our job to help them find some perspective in that. But when I stop and think about what I love to do, what helps me get through the day, what helps me love my life, it's all sorts of things that don't necessarily even have any purpose. Playing with my dog, you can say that has a purpose, exercise. I love riding my bike. You could say, oh, that's transportation or it's for exercise. I say, yeah, but if you told me that bike riding is worse than smoking for you, there's new data, I'd still do it. There's just something about the feeling of it in real time. It doesn't take any time, it doesn't take any thought. And again, if our goal is to really be there and to live until we die, purposelessness, meaninglessness, mystery all have a huge, huge role. Okay, I'm babbling, guys. We only have 20 more minutes. So let me just say this. This is another, so what is it? What is it about being human? It does seem like we're a little different from every other species. Maybe that's hubris talking or arrogance, but it does feel like we're a little bit different. What can we do? Well, we humans, there's so much about our lives, and I learned this after my accident in college, that I couldn't change so much of the facts of my life. I couldn't change them, no matter how hard I tried. And I see this in my patients. They would love to change their situation, but they just can't. It's impossible. But what they can change is their point of view and their perspective. So how we see the human ability to change your lenses is an incredible skill. It's one we should exercise with ourselves and each other and our patients all the time. So we're living a time where we all know what the world looks like. You could look at it this way. You could pull back on the lens, see the world as a single object. We are all one. Nothing divides us. We are all together, all one. Or we can pan out even further, see our world in a galaxy, and we're one of a gazillion. Or pan in, these are virus particles, and you could see that a body, my body, your body, is a universe unto itself with 8 gazillion creatures living on it. It's just, and all of those stations are true. All of them are accurate. So what the deal is that we humans can zoom in, zoom out. We can change our context. It's an incredible skill. And it's an interesting trump on reality. This is the way we forge reality. We won't just accept it. And for my money, again, when someone's beyond cure, being able to exercise perspective making, super powerful force. And it really comes from tending to yourself. All of us know how to do this for ourselves. It's harder to impart with patients. Okay, there's a few more slides I want to get through, but the clock, let's see here. Let me just spend a moment on this, guys. So this is one I wish my teachers had taught me. There's a big difference. Like humans, we're so good at noticing contrasts. Literally, we only see light when it hits something dark. We need contrast. We thrive on it. And we notice, we observe, we discern distinctions. Beautiful, important. It's a way of appreciating reality. But then we humans do this extra little thing. We have this other impulse that takes us, not only do we notice differences, but then we heap values and judgments on them. That's what this unnecessary pain that we do to each other. And that's where good clinical work, good medical work is so powerful. Have you guys known this feeling in your lives where someone just sees you everything that you are, whatever you are, warts and all, whatever, missing parts, whatever, but dares to see you, just looks at you for all that you are, not that what they want you to be. It is the most gorgeous moment to be in with someone. And what can ruin that moment? Judgment. Just in an instant, you can erase all of it. So if we want to get really good, if we're really in this, if healthcare is a service, this is a really important muscle. Discernment, see people, bear witness, but watch the impulse to judge. Okay, this one's too good too. The power of impossibility. This is one I learned, and I think we like to think that anything's possible, and yeah, especially out in California where I live. You feel like there's nothing, just your imagination is your only limitation. Yeah, anything's possible, but not everything. Not everything is not possible in this one life. And that ends up being kind of a distraction. And we orphan ourselves from the truth, because some things in this life are just not possible. And there's a power to that. In medicine, we really smear this line. You be with a patient, you're telling them all the things that are going wrong and all the things that aren't going to work. And you're groping for something to offer them, some choice, because that's freedom. You see freedom being pulled from them, you want to give them freedom, give them choice. So we offer these choices, clinical choices. The problem is we often offer things that aren't going to be helpful. We offer futile care sometimes. And that ends up becoming, like we've talked about, a waste of someone's time and resources. And that, to my money, is really the new negligence. That it used to be that negligence would be not trying to do everything you could. Now, actually, knowing that we can hurt people, exercising the judgment of knowing when to not do something and when to call something impossible. You guys know this. When something's impossible, you don't waste too much time fretting about it. The second someone says, well, if you try hard enough, if you find the mystery of the key, if you solve it, then it's possible. If you give me 1% chance of something being possible, then it revs me up. And it gets me wanting to try and crack the code. But if that's a folly, if that's like a false, that's not really real, then it's just a waste of time. And then I've also missed out on the relief of impossibility. When something, like my limbs, when they were gone, they were gone. The clarity of that was very useful. It was sad, but it was very clear and very helpful. If someone said, well, if you push hard enough, maybe you can spring new limbs, I would have tried really hard to do that. And I would have felt like a big failure if I hadn't been able to do that. But when something's impossible, you're innocent. And this way we make patients feel like a failure for dying is so unfair and so unkind. All right. We are the dying. Sorry, you guys probably know that already. I don't need to spend much time on that. The point here is we should be careful that we don't accidentally separate ourselves from each other. The truth is we're all dying. When we say the dying, the they, the homeless, the poor, you put the there, you're saying, I'm not those people. I might care about those people, but I'm not those people. So watch the. Okay, lastly, really, this one I learned, this is a really powerful one for me personally, therapeutic. When I learned this, so I was in college, I'm becoming able-bodied and moving to disabled. As I'm an independent person, now I'm becoming dependent. And the language and the sort of affect around it all was so harsh. It's so because the world is sort of created for able-bodied people, independent people, certainly in this country. That's the kind of spirit of it. So you feel like you're going to this lesser world. That's part of the trauma of it all, and the sorrow of it all. But the truth is, there is no such thing as independence. Has an independent person ever walked this planet? No. Is anyone who needs no one? No, it's not possible. We need each other. It's just a matter of degree. So we start seeing for ourselves and for our patients this sort of spectrum. I didn't leave one world and join a lesser one. I just moved down the spectrum about a millimeter. I became relatively a little bit more dependent, maybe relatively a little less independent. But it was coming to terms with that meant, God, it was so much less far to fall. And therefore I wasn't as traumatized when I realized this. Okay. Now we only got 11 minutes left, guys, so let's do the Q&A. But while you guys are going around with the microphones, let me just say this is a painting by Nicholas Poussin. I'll leave with this. Et in Arcadia Ego. I too exist in paradise is what that means in Latin. These happy guys wandering in paradise come across a sarcophagus and looking at this god, at a goddess saying, what's a tomb doing in paradise? And what's death doing in paradise? At an Arcadia Ego, I too exist in paradise. The I here is felt to be death. And that's the sort of counterintuitive. What is death doing in paradise? Well, you start thinking about it. What makes anything precious but that it ends? If we were to experience paradise, we have to understand that it ends. That will allow us to experience, to feel it. So on some level, death is essential. So that's one point. And the second point, I'll just simply ask you guys, if you could push a button and live forever, would you push it? No. I mean, it's amazing. It's a silly question because the button doesn't exist as far as I know, and depends how, what state you'd be living in forevermore, et cetera. But my point is simply a sort of a gut check. Death really, ultimately, at some point, isn't the enemy. And it's a good thing, because death would be a crappy enemy, because death will always win. That does not pay. So anyway, I will just leave with that last sort of thought as we try to find a sort of a worldview as an industry that incorporates the full spectrum of reality. Okay, thanks guys for listening very much. Thank you. Any questions or comments or any thoughts? And I guess while you guys, oh yeah.
You mentioned you alluded to your accident in college.
Mm-hmm.
I was wondering if you could talk about that a little bit more, your experience as a patient of the healthcare system and how that might have informed your journey as a clinician.
Yeah, happily. So electrical burn, sophomore year of college, landed me in a burn unit in New Jersey, St. Barnabas Hospital for months. And, it was pretty touch and go there for a while. And it was my introduction to death. It was that began my relationship to death. And it's been quite a wild ride. I will say, before I forget, the experience as a patient was remarkable. I got amazing care. And again, my criticism of the system is not, there's a lot to love in this world. And I got great care. And it was amazing. So part of what informed me going into medicine was the feeling of receiving all that love. But also the critiques we've described, the accidental ways we separate ourselves and accidental ways we offend. And one of those things that experience cracked open for me was the reciprocal loop between caregiving and care receiving. It's not caregiver up here, care receiver down here. That there's an exchange going on, and that's when it's working well. And that's really informed my thinking as a physician and as a teacher at UCSF. I teach your students that you really, if you want to be the best doctor you can and be the most therapeutic you can for your patient, well, for one, take something away from them, gain from the experience of being with them. There's a phrase called pathological altruism, which is this sort of old school way in medicine. The way I show, as a doctor, the way I show how much I care is I don't sleep, I don't eat, I don't have a personal life. That's the currency. You know how much I care because I don't have those things. I haven't slept in 3 days. That's how much I care. Doesn't really work very well. The truth is, you really want your doctors to be fed by these experiences. You want your doctors to be dealing with the truth of their lives, of the needs they have too. They're much more thoughtful people to their patients. So understanding that loop has helped me inordinately in my own way through healthcare, and I learned that as a patient. I learned this sort of independence, the myth of independence as a patient. It was a remarkable experience. I was going to say I wouldn't trade it for the world because I can't. I would like to think I could learn these lessons other ways, and I'm sure I can, because the final thing I'll say about it is what I did learn is that because we all suffer, mine was dramatic and obvious, but it's a variation on a theme. It's no better or worse than your pain and suffering. It's just a little dramatic. So anyway, there's much more I could say about that experience, but that's a little bit of a highlights. What else, guys?
Hi, Dr. Miller. Thank you so much for your very thought-provoking talk here, challenging all our ideas around healing and even right now independence, mortality. So I'm just curious, all these thoughts are formed in us through our culture, and you're critiquing our Western culture, our Western delivery of medicine. I'm just curious if You've visited other cultures, observed other systems, and if there's any that are more aligned or in tune with the ideas that you're sharing with us.
Yeah, it's a great question. I mean, I keep wanting to apply for some sort of grant to protect time to go travel the world because the subject's so dang fascinating. How people experience life and death and illness. I mean, humans have been doing this a very long time. There's nothing new here. So there's so much to learn from other places, other people. It's just fascinating. I haven't done that yet, but from what I understand, I mean, from a sort of a systems point of view, the UK, the Scandinavian countries tend to do palliative care and end-of-life care pretty well because it's integrated. I think as a general, so I can say that, but sort of Eastern cultures, one of the tells in our country, one of the ways you know that America as such is or the U.S. is such a young nation, is how we treat aging and dying and all the sort of facts of life. We haven't, as a country, we really haven't given in. We haven't copped to the idea that we die. We really haven't done that. And it's a way, and we haven't really copped to the idea that aging is normal. We keep thinking, we say, oh, you eat enough kale, don't smoke, do this or that, use this cream, and all this, it implies that aging and dying is somehow optional or a failure. And these are all the ways you can tell that U.S. is, I mean, this country, we're like, basically, my point of view, it feels like we're like a big dumb teenager. We have way too much power that we don't know what to do with it, we're awkward, hormonally driven beasts, and it shows. So I will simply say, I think I use this lens as a way of critiquing the sort of immaturity of our society. And I think anywhere you go to a culture that's been doing their thing for more than a couple hundred years as a group, you will find that they do death and suffering a little differently. Think of India, think of where cremations happen in public. The basic idea, I think, with the wisdom there is that you don't separate death from life. That in fact, those things are integrated. They're not opposed. They're absolutely part of a single whole. And any culture that's copped to that, in my mind, is ahead of us, at least in these ways. Okay, guys. Well, I will say, maybe, I don't know, it's interesting. I don't know. Hopefully this conversation feels relevant to your work as a human being, as someone in healthcare. And also, even if I'm all for technology and innovation, it's a beautiful thing. I guess I just want to make sure we all understand. I'm just trying to inform an ethos underneath all this activity, sort of a touchstone where we can remind ourselves why we do the work we do and to what ends we're trying to do it. I think healthcare as an industry becomes, internally informed. Our goals are internal. That's where we get into trouble. Healthcare for its own sake. Just want to remind ourselves that healthcare is one big, but one among many ways of understanding life and helping each other and pursuing love and goodness in life. So anyway, I hope that I hope you see the relevance of this kind of conversation, the work you do. If you don't, I'd love to hear from you. So if anyone wants to drop me a line at bj.miller@ucsf.edu. This is sort of my life's work, and so I'd love to hear back from you for concerns or criticisms or anything like that. Yes, ma'am. So the question was, where do I see the forecast, the future of palliative care? So I'm watching it move from, it was in so hospice came in the 70s to the US. Palliative care per se started in the 90s, really, and got going in the 2000s, and largely set up in the hospitals. So most palliative care programs started in the acute care setting as a consultation service. And they learned from the mother of palliative care really is hospice. The learning has been, you do all these, you work at end-of-life care, you see all this interdisciplinary work, all the things we've talked about, all these sort of beauty is in the mix, people are healing in this profound way, there's humor, there's all sorts of things happening at the end of life. And the norm is, we go into this field, I was attracted to end-of-life care myself. I went into that first, and I was like, well, geez, why don't we do this earlier? Why are we not thinking about these things earlier, where we have time to reap the benefits of them, of all the lessons learned, et cetera? So palliative care took that idea of end-of-life care and said, why are we waiting to be dying to do it? So that's been the stream, moving upstream. You saw that definition of palliative care, no mention of death in it at all. You guys, I hope you know this. You don't have to be dying anytime soon to get palliative care. Hospice, you go into hospice, you give up other kinds of care, and a doctor has to say you have 6 months or less to live. There are no such criteria to qualify for palliative care. That's an important thing to know. You can get the most aggressive care right alongside palliative care, and that's actually when it works best. So I'm laying that out to say I think we're just going to keep following that, trying to sort of proselytize these concepts, push them further, deeper into medical curricula, deeper into the experience, of being a clinician and being a patient. So that's one answer. The second answer would be moving from the acute care inpatient setting. Then there was outpatient palliative care. I've been working at an outpatient palliative care clinic since 2007, and that was one of the first in the country. So this is all pretty new. And now you're seeing palliative care in the home, palliative care in nursing homes, long-term care settings, et cetera. So I think you'll see it fan out as a site of care and places of care, like it's already doing. But I think the philosophy is set. It's like an aspiration. We're trying to achieve, palliative care is still more a promise than a fact, really, in a lot of ways. All right, guys. Well, again, thanks so much for listening to this. I really appreciate you having me.